And a pleasant day, well, or evening if you're watching it night, to everyone. Instead of some remastered content, this time we have something brand new because I could not stand ANS claiming drugs over there as ANS drugs. And some of them are clearly CNS drugs, as you will see very shortly. And especially with the pandemic, there's been a lot of talk about ADHD. Some people thinking they have it, some people eventually actually getting diagnosed with it well into their adulthood. And some people, of course, mental health services are just inaccessible, so it can be very difficult to really figure things out. And I myself am getting assessed for ADHD. I'm gonna find out my results next week, so I'm staying tuned for that. But in the meantime, for those who are curious, for those who might have friends who are thinking about this, who might be considering medication treatment, we often tend to skim these parts of ANS, right? So, a bit more detail this time around. When we talk about ADHD, it might sound small, petty for some people, but when we talk about the cognitive dysfunction, executive dysfunction underlying this disorder, this can have far-reaching impacts on a person's quality of life, even their risk of death, actually, seriously. So, the manifestation, though, can differ depending on when you first catch on. This is actually something that will be present long before, meaning starting childhood as early as 12 is when you would be ideally first making the diagnosis. At this stage, you would see a lot more hyperactivity, for instance, symptoms. But as we grow older, particularly now, as more adults are realizing that after the COVID pandemic has worn away all their coping mechanisms, only now they are realizing that they may have some ADHD. Catching it in adulthood, you might see less of the hyperactivity, but more of the inattention, concentration difficulties, difficulty organizing, or just getting started on tasks. Impulsivity also goes down, but it can still be there. So, yeah, it's a neurodevelopmental disorder that symptoms may differ depending on when you figure things out. One very, very common myth: sugar. The sugar cause ADHD. I'm going to tell you as early as now, that's a myth. Diet has nothing to do with your risk of ADHD. Several observational studies have failed to find even a correlation to this. So, as usual, a combination of genetics, psychological factors, the environment, systems that really tend to value a more neurotypical mind as compared to, being more inclusive with accommodations for those with a more neurodiverse brain architecture. So, yeah, it's not the sugar. Trust me on that. But I'll show you the reference later if you don't want to trust me. Of course, that's fair. Okay, now we go on to meds, because again, meds might get a bad rep for thinking that, people with ADHD just want to get ahead, perhaps, or something like that. I'm not really sure. But really, when you look at how the meds work, you realize it's not trying to gain an advantage, but simply trying to attain the same quality of life that neurotypicals often have and often take for granted. Actually, how exactly does ADHD work from a neurobiological perspective? Well, on a molecular perspective, something pharmacy students and pharmacists are a bit more comfy with. Two receptors play a key role here, of course, coupled with key monoamines, norepinephrine, and dopamine. What do these two receptors have to do with the symptoms of ADHD? And I was thinking about the symptoms being difficulty concentrating and all of that, and I thought of using the cell phone as an analogy for all of this. Let's start with this one. Okay, I'm sure during the pandemic, because I don't know, some bungling institution or individuals managed to mess up our data privacy, I'm sure at least some of you have gotten all of these spam messages. I'm gonna hide their numbers because they decided to, screw with ours, so whatever. When you're trying to contact people, trying to organize communication on your phone, and you have all of these spam messages, it makes keeping track of things very difficult. It makes organizing, it makes focusing very difficult. Spam, or we can think of it as noise. So in a person with ADHD, their brain has a lot of noise that is not being filtered properly. And one thing we can look at is improperly tuned D1 receptors. So dopamine type 1 receptors. The dopamine type 1 receptors are linked to an ion channel. So what happens when there is improper tuning of these D1 receptors, particularly in the prefrontal cortex, the part of the brain responsible for, executive function, concentration, cognitive function, etc. What happens if there's improper tuning is the ion channel remains closed. So you have all of this spam, all of this noise in the brain. So all of that, and the ion channel is closed, meaning all of that spam is not drained off properly. It's stuck in the inbox of your brain because the D1 receptor is not tuned properly. So because of that, there's too much noise, and there's too much noise in the brain, like in your phone. It's very hard to concentrate. And that's one way the symptoms of ADHD may manifest. Now, what about the norepinephrine section? So this was dopamine, right? Dopamine and D1. What about norepinephrine? So norepinephrine binds to several adrenergic receptors, but the key one in the brain is alpha-2. But you might be wondering, what is that alpha-2A? Well, surprisingly, alpha-2 is not as simple as we often teach it to be. But to keep things simple, since we're not yet at clonidine, one of the key receptors that regulates attention, impulsivity, etc. in the brain is the alpha-2A, so subtype 2A receptor. So there are 3 subtypes that are scattered between the CNS and ANS. One of them is alpha-2A. Alpha-2A receptors function differently in the brain, and they regulate attention, impulsivity, and these receptors are bound to by norepinephrine. But what happens if these receptors are improperly tuned? If these receptors are improperly tuned by norepinephrine, the ion channel associated to it remains open. And what does this ion channel end up leaking out? Signal. I'm sure during online classes, you found it very difficult to stay focused when the foremost thing in your mind was maintaining an internet connection, right? It's been very difficult. So signal is very important. A strong signal in the head is very important to stay focused. And if your alpha-2A receptors are not properly tuned by norepinephrine, the signal becomes too weak because it drains out of the ion channel and it becomes very difficult to focus. In comes your medications for ADHD, right? So normally we have catecholamines in the synaptic cleft. After they finish binding to the receptors, they undergo reuptake through their respective monoamine transporters. You have the dopamine transporter and the norepinephrine transporter. I got the labeling right. Okay, what happens then if a drug blocks these transporters? Let's say we visualize them as forklifts, pickup trucks, whatever, and you have a drug that kind of flat tires them, naflatan sila. So what happens is your dopamine and norepinephrine, they are stranded. Right? They are stranded in the synaptic cleft. What else are the monoamines going to do when they are stranded at the synaptic cleft? Well, what else but bind to their respective receptors. And this time in ADHD, you wanna use that opportunity to properly tune them. And that is where methylphenidate comes in. Methylphenidate can block both the norepinephrine and dopamine transporters, NET and DAT. And so your norepinephrine and dopamine neurotransmitters, they are stranded here in the synaptic cleft. What else are they gonna do? They're going to bind to the receptors, dopamine to D1 and norepinephrine to alpha-2A to properly tune them. What happens when they are finally properly tuned? So dopamine binding to the D1 receptor, properly tuning that, finally the ion channel will open. So in this case, dopamine to D1 is more stimulatory, stimulates the opening of the ion channel. And all of that spam, all of that noise, so annoying, finally just drains out of your brain, your phone. It's just, finally, it's quiet. I can focus. Okay, so that's one way it works. Now, on the norepinephrine side, so when the norepinephrine finally properly tunes the alpha-2A receptor, this leads to an inhibitory function. The ion channel closes. The ion channel that was leaking the signal of your brain finally closes, so the signal is strong. So earlier, you had too much noise, and too weak of a signal. Now, with proper tuning, you have less noise, it's more quiet, you can focus, and a stronger signal. Right? So the important signals, you get to boost them. The unimportant noise, you get to drain them out. And that's what methylphenidate helps with in terms of ADHD symptoms. Isn't that just great? So, these things might not seem like problems for neurotypical people, like, just focus, don't procrastinate. Again, you have no idea how easy you have it in terms of this. I'm not saying in terms of everything. In terms of this, you have no idea how easy you have it. So, hopefully, you can use this as an opportunity to empathize with people who may be struggling with ADHD. Right? So, all of that noise, that weak signal, it makes it very hard to pay attention. Okay. Now, besides ADHD, methylphenidate actually has another indication, and that is narcolepsy. Narcolepsy is a sleep-wake disorder we don't often talk about. It's less common kasi it involves a lot of daytime sedation and also occasionally involves what we call cataplexy, so muscle weakness on occasions like when you suddenly laugh and then you suddenly end up slumping or falling because your muscles weaken. So that's short explanation of cataplexy. Unfortunately, methylphenidate only works for the daytime sedation symptoms of narcolepsy because dopamine, but when methylphenidate blocks the dopamine transporter, so you have an increase of dopamine, the synaptic cleft. Dopamine itself is a wake promoting neurotransmitter. So dopamine is like histamine in the brain in that they both promote wakefulness, and promoting wakefulness is very important when the disorder you have makes you sleepy during the day when you're not supposed to be sleepy. So you want a bit more of that dopamine to help stay awake. That's where methylphenidate can help. Unfortunately, methylphenidate does not help with the cataplexy symptoms, but because we only have very few meds that work for narcolepsy in the Philippines, we'll take our options, I guess. But despite that, for ADHD, at least methylphenidate is first line, which might feel weird to some because isn't methylphenidate similar to amphetamines? Well, yes, but it works. It works. I mean, within an hour, it's going to work. Very few psych meds that work that fast. So benzos, they work within the hour. Methylphenidate will also work within the hour for the immediate release, right? And imagine the duration is about 4 hours. Imagine 4 hours of noise, of weak signal just alleviated kahit papaano. It's just really the things we take for granted. Because it's wake promoting, you want to take this at a time when you'd be awake and productive. If you're a day shift, you'd be taking this in the morning. If you're a night shift, you'd be taking this at night. So it really depends. While you might be afraid it may be similar to amphetamines, rest assured, the side effect profile in terms of the addiction part, in terms of addiction, here's the thing. If you're so worried about methylphenidate, I would advise you to worry more about alcohol and tobacco. Tobacco is the most addictive substance in the world. More so than shabu, more so than cocaine. Then you have alcohol, the most dangerous yet legal drug in the world. So if you are worried about methylphenidate, my friends, let me tell you, there are much bigger things to worry about. The addiction risk for methylphenidate, relatively low compared to the benefits. The benefits, because it really works for ADHD. The noise gone, the signal boosted due to tuning of the D1 and alpha-2A receptors. It's worth it. It's worth it, definitely. So, if I were you, I would worry more about alcohol and tobacco than I would about methylphenidate. Methylphenidate is like at the bottom, lower than the bottom of the list of things, of drugs I am worried about for their addiction potential. It's just, yeah. The benefits are just really so worth it. I mean, of course, if the person has comorbid substance use disorder, you would exercise due diligence with monitoring, but in general, it's really not a big concern, really. Even the cardiovascular stuff, I mean, a black box warning, I mean, it makes it look like a big concern, but if it were really a big concern, this drug wouldn't be on the market. Of course, you would still do your monitoring, but it's not really a big concern if you have no underlying cardiovascular problems or no family history, right? What I would worry about is how atrociously pricey this drug is. ADHD meds in the Philippines, we only have 3 that actually work. 2 of them, the ones that are frequently known to be used for ADHD, are just super pricey. For my new cheat sheet, they're about like a level 4 in terms of financial toxicity. So I'd worry more about how atrociously expensive these meds are, given the quality of life they bring to people with ADHD. Right. These side effects, the general ones, you can kind of rationalize them from the increase in norepinephrine and dopamine in the synaptic cleft. So for instance, nausea, so the increased dopamine will bind to D2 receptors in the chemoreceptor trigger zone, so increase in nausea. And then insomnia, because obviously dopamine is a wake promoting agent, and so on, so forth. Right? Also mind that any drug that elevates monoamine neurotransmitters in the brain, particularly serotonin, dopamine, or epinephrine, may lead to manic switch in those with bipolar disorder. So again, they cannot induce a new diagnosis. They simply unmask what may already be there underneath. Okay, so manic switch is precipitated from an underlying bipolar disorder. It's not something that's like out of the blue, right? So yeah, that's the gist of methylphenidate. Interactions wise, you just really got to worry about the increased absorption with drugs for the GERD drugs. But depending on the service user's discussions with their clinician, they may choose to mobilize this interaction to their benefit. So again, it depends. Unfortunately, because methylphenidate looks a lot like amphetamine, it may come up as a false positive, even though again, it really shouldn't matter, but this is just an absolutely garbage test. So yeah, just be mindful of that then. Alright? This one falls under one of my notable exceptions. One of my notable exceptions when talking about branded and generic. Now, I love the generics law. I love it to bits. But it just doesn't have that nuance that we have in day-to-day clinical practice, particularly when you talk about biosimilars, quote-unquote generics of the peptide drugs, the 100-chain amino acid drugs, for instance, or narrow therapeutic index drugs like lithium, right? When that tiny difference in pharmacokinetic profile may impact a clinically significant change on outcome. So in this case, this has been found to be the case for methylphenidate. For methylphenidate, they have found regardless of bioequivalence, when you switch brands or generics or whatever, outcomes can change. So the advice from clinical practice guidelines is don't switch. Take note, I am saying don't switch. The operative word being switch. I am not saying branded is better. I am not saying generic is better. I am saying don't switch. Meaning if you pick a formulation, it's recommended to stick to it all throughout. Meaning from the beginning, it's recommended you pick one formulation you think you will be able to access, to afford, and your drugstore will likely not run out of stock anytime soon. You can ask the pharmacist there, of course. Now, in the Philippines, we only have like 2 brands. One brand has an immediate release and a long-acting. So, technically, 3 formulations. So, not too many to pick from. All are still very pricey, unfortunately. But the advice is, do not switch. Okay, do not switch. We have seen outcomes change when people switch. I'm not saying any is better. I'm just saying stick to one, specifically for methylphenidate. So those are my exceptions in psych: lithium, methylphenidate, clozapine. For these 3 drugs, I tell people do not switch. Alright? But I'm not saying any one is better than the other. I'm saying stick to one. In short, maging loyal. Just for these 3 drugs in psych. Okay? No. Featuring atomoxetine. So atomoxetine is the other ADHD drug I mentioned in the Philippines. One thing you might find weird about atomoxetine, though, in terms of its MOA, you'll notice the norepinephrine transporter. Why does the norepinephrine transporter also carry dopamine? Was that a typo? No, that is very, very intentional. In the prefrontal cortex kasi, the part of the brain, again, responsible for cognition, executive function, etc., there are not many dopamine transporters, if any at all. Well, basically, there's a lot more norepinephrine transporters. And dopamine, it's like public transpo in the Philippines. Anyway, not enough transporters, so dopamine is forced to hitch a ride with the norepinephrine transporter in the prefrontal cortex. Meaning, in that specific part of the brain, if you have a drug that blocks the norepinephrine transporter, you can increase levels of both dopamine and norepinephrine in the synaptic cleft. There. So atomoxetine, in effect, although it only blocks the norepinephrine transporter, it can also raise levels of dopamine in the synaptic cleft. And again, as I mentioned earlier, that can lead to better tuning of the D1 receptors and the alpha 2A noradrenergic receptors. So tuning D1 receptors, less noise, better focus. Tuning alpha 2A receptors, stronger signal. I can focus better. Right. So one conception you might have is that atomoxetine, it's not like amphetamine, so it's better. Not necessarily. These drugs have their pros and cons. In fact, consensus clinical practice guidelines would consider atomoxetine as second line to methylphenidate. What? Really? We prefer the scheduled drug? Yeah, methylphenidate is an S2 drug, right? So you prefer the scheduled drug over the non-scheduled one? Yes, because it tends to, number one, it works faster. Look at the onset of action for atomoxetine, right? 4 to 6 weeks. Sure, it's not like an amphetamine, so less issues with S2, no issues with the marginal addiction potential, right? Pero that's 4 weeks. You know, think about it like in a school year. How much schoolwork is 4 weeks? Imagine losing out on that much quality of life, productivity, simply because of our prejudices, biases towards drugs. 4 weeks? Really? I'm not bashing atomoxetine fully. It has its place. Like, for instance, for people who might have underlying cardiovascular issues, right? Methylphenidate might not be suitable for them. Then that's where atomoxetine can come in. Fortunately, like methylphenidate, atomoxetine is still atrociously expensive. So, gotta choose our poison, I guess. But yeah, in terms of the cardiovascular stuff, the increases in heart rate and blood pressure tend to be negligible, and otherwise side effects are very similar. You might see a bit more of the genitourinary side effects because, again, increasing norepinephrine levels may lead to increased binding of alpha-1 receptors in the bladder, which can lead to difficulties with urination. But methylphenidate also blocks norepinephrine reuptake, so not impossible for methylphenidate to cause that din. But in any case, side effect profile is similar because the mechanism of action is similar also. One particular difference for side effect profile is methylphenidate can cause a withdrawal syndrome when you stop. Diba? That's what dependence means. Dependence and addiction are different, right? So dependence means if you suddenly stop a substance without tapering, it can lead to a very unpleasant withdrawal syndrome. So methylphenidate has a very small addiction potential and can cause withdrawal if you suddenly stop. Atomoxetine so far has not any documented withdrawal syndrome if you abruptly stop. So that's another thing. Non-adherence will not be as punishing, at least for atomoxetine. So that's another factor you might want to consider, right, for atomoxetine. Interactions, mainly 2D6 inhibitors and inducers can affect the levels, and of course, the usual false positive with the trash drug test. And one of my favorite slides. So we've been talking all about the side effects, interactions, blah, blah, blah. But at the end of the day, whether you ask the teachers, whether you ask the clinicians, the parents, or the service users themselves, the meds work. Atomoxetine, methylphenidate, they work. They work for ADHD. And not just for the core symptoms. They work, my friends. They work. I was actually surprised to learn about this. Now, it's not just about the attention span, about concentration, about having a more organized workflow, but also, look at this, less vehicular accidents. I'm kind of glad I decided not to take my driving lessons yet until I got my ADHD assessment because, maybe difficulties with concentration, impulsivity might, make you more accident prone. And meds can reduce that directly. They can we're worried about, oh, methylphenidate has addiction potential, but overall, meds can actually reduce substance use. Would you look at that, right? Would you look at that? What else? Decreased teen pregnancy, decreased suicide. Right? So it's not just the cognitive stuff. You also have several more. I think we can say this is more than quality of life. This is literally life. Look at the suicide. Literally life. This life thing. Academic performance might be controversial. Let me just say, for all of those who are having thoughts now, if you don't have ADHD, the only thing you're going to do with methylphenidate is to increase your blood pressure. That's the only thing you're going to do. Okay? Methylphenidate will only work for those who have ADHD. If you don't have ADHD, don't even bother. You're just going to raise your blood pressure for nothing. Good luck. Don't. Okay, don't bother. If you'd like to know more about the other trivia about ADHD, you can check it out here. So, for instance, other side trivia. People have been saying, oh, ADHD, that's a millennial thing because of smartphones, computer. Well, actually, no, truly, seriously, actually, ADHD has been documented to exist since the 19th century or even earlier. I can't recall what the facts have been saying, so you can check them out here at the World Federation of ADHD International Consensus Statement. They have documented facts about ADHD. It has been around for a very, very long time. Yeah. Our brains really hate us, no?